So good morning, everybody. Today we are going to talk about the veins of the major circulation. It means an overview of the most of the veins of the body. Hopefully we are going to finish everything. So this is the reference. Regarding the veins, we divide the veins to three classes. The large veins, the small and medium veins, and venules. The large veins, they are more or less the same as the medium or small. The difference is belong to the smooth muscle in the tunica media, that in large veins they have a little bit of the smooth muscle in the tunica media, but they have the thickest layer of the tunica externa that we discussed it before. The example of the large vein, for example, superior vena cava, inferior vena cava, portal vein. Small and medium veins, they have some amount or a small amount of the smooth muscle again in the tunica media, and also the thickest layer again is the tunica externa. For example, the superficial veins of the upper and lower limb, like the cephalic basilic, and the great saphenous vein and small saphenous vein, and some deeper vein in the leg and forearm. The venules, you know that they are the smallest vein, and they are connected and they are drains to the capillaries. Regarding the veins usually compared to the arteries, they have some distinguished feature. As we said, specifically in the tunica media, the veins, they have the tunica media very thin, but vice versa of the artery, they have the luminal diameter of the veins, they are large, so they are containing the volume of the blood inside this vein. And also another characteristic of the veins, especially in the peripheral region, is that usually the veins in the deeper layer, they are going accompanied with the arteries. They are called vena comitans, and usually they are more than one when they are parallel with this artery, the wall of the artery they are passing. Another difference between the artery and veins, usually the veins, they are containing the valves, and especially in the peripheral vessels inferior to the level of the heart, because they have to pump the blood against the gravitation, and that's why they need this functional system of the valve, that they can facilitate the blood flow toward the heart. Here you can see the mechanism of the valve, that how it's working. Usually it's composed of two cusps, and there are two very important mechanisms that they are pumping the blood inside the vein. One, especially in the limbs, especially lower limbs, you see the function of the skeletal muscle. The contraction of the skeletal muscle is causing the contraction of the wall of the vein and pushing the blood toward the heart, and these valves, they are helping to prevent the reflux of the blood back to the lower or the distal segment. So one mechanism is by the contraction of the skeletal muscles. The other one, as we mentioned, usually the veins in the periphery, they are multiple, so they are usually the double. So they are in the both sides of the artery they are passing. So by the pulsing of the artery, by the flowing of the blood through the arterial wall, so they are compressed, the wall of the veins, they are compressed and they are pushed toward the valve. And these two mechanisms, by the pulsing of the arteries and the contraction of the skeletal muscle, they are helping to push the blood toward the proximal part and toward the heart. And in this case, the the blood can reach easily to this part of the heart, the right atrium, against the gravitation. So of course, you have seen, you might seen some varicosis vein that it happening during to the non-functional valve. So if the valve is not usually working well, so the blood, it will be refluxing back from the deeper layer to the superficial vein, because as you know, the superficial vein and the deep vein, especially in the periphery, in the lower lip and in the upper limb, so they are interconnecting together, and by the perforating vein they call it. And at this region we have some valves that they are adjusting the blood from the superficial to the deep vein. And if this valve, it doesn't work, so there is a reflux of the blood from the deep vein back to the superficial vein, and that's why the vein, it become dilated and tortuous shape, and that's why it's called the varicosis vein, and it's visible under the skin because they are usually affected by in superficial veins. So this dilatation and tortuosity of the superficial vein is very seen during the pregnancy, for example, is usually happening in women than men, and mainly is related to the non-functional valve. And sometimes in the severe case, the color of the skin, it becomes pigmented, and it's very prone to the trauma. And in this case, with very minor trauma, it can be ulceration happening, and in this case, it's necessary to do the excision of these veins, or the strip or removing of these veins from the body. So this is the clinical importance, that how this superficial vein and the deep vein, especially in the periphery, they are communicating together via the perforating vein. And if there is a dysfunction of this valve, so the consequence of this damage is the varicosis vein. As you know, regarding the major circulation, we have two main major circulation, venous major circulation, which are superior and inferior vena cava. So this superior and inferior vena cava, they are carrying the deoxygenated blood from the whole body, and they are give it to the right atrium, and from the right atrium, of course, to the right ventricle, through the right atrioventricular orifice, and then it's pumping to the pulmonary trunk, to the lung, to exchange of the carbon, the oxygen and carbon dioxide. So this superior vena cava and inferior vena cava, they are located in the right side of the body more. So there are some veins that they are parallel with these veins, and in the left side, that they are shifting the blood from the left side to the right side, that we are going to discuss. This is one important aspect, and the other is, as you see, the superior vena cava, which is located in the superior mediastinum. It's formed by the junction of the two brachiocephalic vein. In the next slide, you can see that the two brachiocephalic vein, the left and right brachiocephalic vein, they join together and they form the superior vena cava, which is farther, it's open to the right atrium. Inferior vena cava, it's formed by the junction or the union of the common iliac vein, the left and right common iliac vein, at the level of approximately L4, the fourth lumbar vertebra. They formed, and then they are going upward, and it's perforating the central tendon of the diaphragm, through the opening of the foramen of the inferior vena cava, and after a short course, it's going to the right atrium from below. So, so this is the two major circulation and two major veins that we are going to discuss about the details about them. In the thoracic region, we have another system of the venous system, or the venous circulation, and they are called azygos system of the vein. So you have seen it in dissection, these azygos veins, I hope, and in the pulmonary system also, when we are showing you the lung in the right side, or right lung, you could see the impression of the arch of the azygos vein also above the hilus of the lung. So what are these azygos system? They are the longitudinal veins that they are in the thoracic cavity. They are going in the right side and in the left side, and they are finally they are opening to the superior vena cava. So they are playing role, very important role, to connect the superior vena cava and inferior vena cava together, that we are going to discuss, and it's called cavo-caval anastomosis. It means the connection between the superior vena cava and inferior vena cava together. And this azygos system, they are composed of three main veins. In the right side, on the right side, we have the azygos vein, which is draining directly to the superior vena cava. On the left side, in the upper part, we have the accessory hemiazygos vein, and in the lower portion, we have the hemiazygos or hemiazygos vein. I have to mention that when you are going to dissect the cadavers, you will see also that a lot of variation, it can happen to the venous system, yes? So the veins, they are the most common structures that they are not exactly similar from each body to the other body. So you can see somehow some variation. So exactly the drainage of these veins, they are not exact and is not 100%. For example, the hemiazygos vein, it can drain to the accessory hemiazygos vein, it can drain to the azygos hemiazygos vein, and then it drain to the azygos vein. It can drain separately to the azygos vein, as you see it here in this picture. It can drain to the azygos vein and also have a connection to the hemiazygos vein. So if you see different literature that they have a little bit different shape, so don't afraid. But the basic information is that ultimately this all the azygos system blood is draining to the superior vena cava, and they are in contact with the inferior vena cava, that they are part of the cavo-caval anastomosis. And it's very important, if the inferior vena cava is blocked by some thrombosis, for example, so the blood, it can bypass to the superior vena cava and doesn't affect very serious complication. This level that you could see that, for example, T5 or T4 is the place that the azygos vein is draining to the superior vena cava. Hemiazygos, approximately, it's at the level of T9. The hemiazygos accessory or accessory hemiazygos is approximately at the level of T7. Again, if you see the different levels, so is variation happening and is not exact level, so in this case. Regarding the azygos vein, what is the azygos vein? Azygos vein is originated from at the level of L1, L2 approximately, by union of the junction of two main veins at the right side. So whenever we are talking about the azygos vein, we are talking in the right side. So definitely don't forget about this right sign. that at these two veins, they are the right subcostal vein and the right ascending lumbar vein. So these two veins, they are joining together and they form the trunk of the azygos vein on the right side, which is in the posterior mediastinum, is going upward, and from the abdominal cavity, then it's going to the thoracic cavity, to the posterior mediastinum via, again, you see that there are variation. Mainly, it's, according to me, it's via the right crus of the diaphragm is entering to the thoracic cavity, to the posterior mediastinum. But as you see, there is a literature that also said that it might pass also through the aortic hiatus, through the opening that the aorta is passing also. So this is Gray's anatomy reference. So in the posterior mediastinum, then it goes upward. It's located in the right side of the thoracic duct, and approximately we see here is T4 or T5. It's making an arch above the hilus of the right lung, or the root of the right lung, and is draining to the superior vena cava, which is important. So if you know the thoracic aorta, approximately you can mention also the tributaries of the azygos vein on the right side. So more or less they are the same, except some veins. So for example, we have visceral tributaries, that it's the right bronchial, the right pericardial vein, mediastinal vein, esophageal vein. And as we said, the main tributary is the accessory as a hemiazygos vein and the hemiazygos vein together, these two, and also the posterior intercostal vein. Here we have the right superior intercostal vein, which is a single vein here that is carrying the blood and is making a drainage from the second till fourth intercostal space, and it's draining to the azygos vein, and then it's draining to the superior vena cava, most commonly. It can be a variation as well. So those are the tributaries of the azygos vein, which is draining in the right side to the azygos vein and then to the superior vena cava. What is the trunk? It's at the level of L1, L2 by the union of the right subcostal vein and right ascending lumbar vein. Here you can see, and is familiar this picture with you, that there is a hilus of the right lung, and above the root of the lung here is the arch of the azygos vein, which is empty to the superior vena cava. May I ask you, in the left lung, above the root of the left lung, there is an impression for? Anybody? If it was here the left lung, we don't have azygos vein, but we have the impression of? Anybody? Yes? Arch of aorta. So in the left side above the hilus of the lung, there is the arch of aorta, is impression, and in the right side is the azygos system. Hemiazygos is the similar of the azygos system, but in the left side. It means that it's formed by the union of the left subcostal and left ascending lumbar vein, and in the lower portion of the thoracic of the abdomen and in the thoracic cavity is entering again through the left crus of the diaphragm, but again it might be through the aortic hiatus. And the hemiazygos vein is draining to the azygos system here, as I said, approximately at the level of T9. So the tributaries of the hemiazygos vein is the same in the lower portion of the azygos system. It means the lower 4 or 5 left posterior intercostal vein. Some visceral tributaries from the esophageal, from the mediastinal, and sometimes, as we said, accessory hemiazygos vein. Also, it can drain to the hemiazygos vein and then to the azygos vein. So they consider also sometimes the tributary of the hemiazygos vein. The accessory hemiazygos in the left side and upper portion of the thoracic cavity, and on the left side, of course, they are descending approximately till the level of the T8 or T7, and then either is draining to the hemiazygos or directly to the azygos system. And the tributary is carrying the the posterior intercostal from the superior part of the thoracic wall. So the 4 till 8 left posterior intercostal vein and sometimes the left bronchial veins, they are the main tributary of the hemiazygos vein. Be careful, here we have the left superior intercostal vein, which is draining to the left brachiocephalic vein. It doesn't drain usually to the accessory hemiazygos vein. Regarding the veins of the thoracic wall, so if you know the artery, so more or less it's similar than the artery, more or less, not always. So the thoracic wall is generally the parallel and copying the pathway of the arterial supply. So if you know the internal thoracic artery, which is branch of the subclavian, and the branches of the internal thoracic artery, so similarly it's the tributaries of the internal thoracic vein, which is ultimately draining to the subclavian vein or brachiocephalic vein. But finally, those veins of the thoracic wall, mostly they are draining to the azygos system as a posterior intercostal vein, or as an anterior intercostal vein to the internal thoracic vein. So which is finally it's draining to the brachiocephalic vein or subclavian vein. So upper posterior intercostal vein in the left side, as we mentioned it, so it's making the left superior intercostal vein, which is draining to the left brachiocephalic vein. But the upper posterior intercostal in the right side, so it's making the right superior intercostal vein, which is draining to the azygos vein and finally to the superior vena cava. This is the two difference between the right superior intercostal vein, which is draining to the azygos vein, and left superior intercostal vein, which is directly draining to the brachiocephalic vein. So this two is important, and again you can see the level of the drainage of the azygos, hemiazygos, and hemiazygos accessory. You know, and we were discussing about the drainage of the superior vena cava and inferior vena cava in the cardiovascular system, that they are draining inside the right atrium. For superior vena cava from above and inferior vena cava from below. They are carrying the deoxygenated blood, then it's going to the right atrium, and then finally to the pulmonary trunk. So if you consider here from the external surface, we have the groove, which is called terminal groove, which is inside determining the crest, which is called the terminal crest, which is separating the smooth part of the wall of the right atrium in the posterior aspect, which is the place of the opening of the superior vena cava and inferior vena cava, which is called sinus venarum cavarum, or sinus of the vena cava, venae cavae superioris and inferioris. And as you see, is smooth, and the superior vena cava and inferior vena cava, they are opening in this smooth part of the right atrium. But this terminal crest that you see, or crista terminalis, separating this smooth sinus venosus or sinus venarum cavarum from the rough part, which is mainly formed by the muscle. Do you know name of the muscle in the atrium? Usually inside the auricle, yes? Perfect. The pectinate muscle, so musculi pectinati, so is the separating the terminal crest from the smooth part, from the rough part of this pectinate muscle usually. So this smooth part is this remnant of the sinus venosus or sinus venarum cavarum, and here is the pectinate muscle. So here again, just I have to mention quickly that we talked about the fossa ovalis or oval fossa, which is the remnant of the embryonic foramen ovale or oval foramen, that the blood, the deoxygenated blood from the inferior vena cava directly, thanks to this eustachian valve or the valve of the inferior vena cava, is going toward the foramen ovale, and directly it going to the left atrium, because the lung of the fetus is not functional. So the oxygenated blood directly from the inferior vena cava is going through this oval foramen to the left atrium. So this is, we discussed it in the cardiovascular system. When we are here, and definitely from the cervical plexus, we are going to discuss about this very important nerve over the pericardium of the heart. There are two nerves. One is the right phrenic nerve, and the other the left phrenic nerve, which are arising from the cervical plexus. The segment, the main segment is C4, is C3, C4, C5, and it passing over the lateral margin of the pericardium together with the vessels which are called pericardiacophrenic vessels. So pericardiacophrenic artery is the branch of the internal carotid artery. So pericardiacophrenic veins is the draining to the internal thoracic vein. So there's a branch of internal thoracic artery and internal thoracic drainage of the internal thoracic veins. So remember, on the surface of the heart, in the right side and in the left side, the phrenic nerve is accompanied with the pericardiacophrenic vessels, so veins and arteries. So this is one important information, and this is the topographical relation of the superior vena cava and inferior vena cava related to the pulmonary trunk, and from the anterior aspect and the posterior aspect, that during to the dissection you have to pay attention that exact location of every of these structure. The right side, the superior vena cava, then the ascending aorta and arch of aorta and pulmonary trunk, the most anterior portion, and from the posterior aspect, how the descending aorta is going posteriorly from the pulmonary artery. Another important information, as you see, that the superior vena cava, as we said, is formed by the junction of the left brachiocephalic vein and the right brachiocephalic vein. So itself, the brachiocephalic vein is formed by the junction or union of the internal jugular vein and subclavian vein. So these two veins, they are joining together and they make the brachiocephalic vein. This place of the union of these two veins is called venous angle or angulus venosus, that we are going to discuss, and it's very important part for the drainage of the lymphatic system as a thoracic duct and right lymphatic duct that we are going to discuss. But what I'm going to say is that this brachiocephalic vein and the superior vena cava, it's located exactly at the level of the junction of the clavicle with the sternum. So at the behind the sternoclavicular joint, and in the close proximity with the connection of the first rib to the sternum, behind this area you can see the junction of the internal jugular vein and the subclavian vein as a venous angle, and the formation of the right and left brachiocephalic vein, which is finally they are forming the superior vena cava, which is going to the pericardial sac and inside and enter to the right atrium. This is very important cross-section of the superior mediastinum at the level of approximately T3 till T4, so that you have to be able to explain from the anterior side to the posterior side what exactly you can find. So you know that the sternum, the manubrium of the sternum, which is located more or less at this level, T4, T3. So immediately behind the manubrium of the sternum is the thymus, is the first structure that in the superior mediastinum you can find it. And then after or behind the thymus, when you are dissecting the cadaver, so when you remove the thymus, which is in children, is much more bigger. In older people, they are going under the involution, and the remnant of the thymus is becoming a fatty tissue there, and you clean this thymus or fatty tissue. Then after that is the venous system, and you can see the right brachiocephalic vein and the left brachiocephalic vein, which is in the T4. They join together and they make the superior vena cava. After the venous part, then you see the arterial system. And this arterial system or arterial layers, they are the branches of the arch of aorta. It means that the brachiocephalic trunk in the right side, and in the left side there is the left common carotid artery and left subclavian artery. And finally the fourth layer is the trachea and bronchi or bronchial layer, which is the trachea at the level of the T4, then is divided at the level of bifurcation, is divided to the main bronchus. So the bronchial layer. So here is the superior mediastinum and the structure. So as you see, between this thymus, venous layer, arterial layer, and bronchial layer, and of course behind the trachea is esophagus, so we have some nerves. So these nerves, one is the right phrenic nerve and left phrenic nerve, that they are very close proximity to the venous system in the right side, and in the left side. In the right side continue with the superior vena cava, in the left side as a brachiocephalic vein. And the other one is the vagus nerve, the left vagus nerve and the right vagus nerve, which is only the left vagus nerve that is entering to the level of approximately at the level of the arch of aorta, is giving one important branches which is looping around the arch of aorta and nearby the ligamentum arteriosum crust, and is going back between the trachea and esophagus as a left recurrent laryngeal nerve. You don't see in the right side the right recurrent laryngeal nerve, because the vagus nerve doesn't reach in the right side to the thoracic cavity, is making the recurrent laryngeal nerve and looping around the subclavian artery, very important. And finally here is the thoracic duct, is another structure that carrying 3/4 of the lymphatic drainage of the whole body. If we go farther and we make the cross-section at the level of T4, which already the brachiocephalic vein and left and right, they join together and they make the superior vena cava, that in the right side you can see. So you can see the thymus or remnant of the thymus here, and now you can see the arch of aorta with these three main branch of the arch of aorta that you could see it in the level of T3. And again the recurrent laryngeal nerve and the right vagus nerve and right phrenic nerve and the left phrenic nerve and left vagus nerve. So this cross section, be careful, it's very important to recognize during to the CT scan or MRI, magnetic resonance. It's very helpful to recognize those structure, those important structure. Here is the nice picture that, if you remember, I mentioned about the left superior intercostal vein, which is collecting the blood from the upper intercostal spaces in the left side. which is going, and it's has very close relation with these two important nerve. One is vagus nerve and the other is phrenic nerve, and is finally is draining to the left brachiocephalic vein. But in the right side, the right superior intercostal vein, it's draining to the azygos vein, and also it has a small relation with this vagus nerve and the phrenic nerve, far from this. And this this is in the right side is draining to the azygos vein. In the left side, as you saw, is draining to the left brachiocephalic vein. Regarding the inferior vena cava, as we mentioned, is formed by the union or the junction of the common iliac vein, right side and the left side, at the level of approximately L4. It's in the retroperitoneal region, and there are drains in the region together in the pelvic region, in the perineum, and in the both lower limb. So it's very important, and as we said, it has a connection with the superior vena cava via cavo-caval anastomosis that we are going to discuss. This inferior vena cava in the retroperitoneal space is going upward, and it's piercing the central tendon of the diaphragm in this area as a foramen of the inferior vena cava, which is approximately at the level of T8, and then it enters to the right atrium. So more or less the tributaries, more or less, not all, the same as the branches of the abdominal aorta, is located in the right side of the abdominal aorta, of course. As you see, there is a renal vein from the kidney, the suprarenal gland drain to the inferior vena cava. In the right side is directly, be careful, in the right side is directly drained to the inferior vena cava, but as you see in the left side, it drained to the renal vein, and then it drained to the inferior vena cava. So pay attention about the two veins in the right side and in the left side that is different. The right suprarenal vein and right gonadal vein, so ovarian or testicular vein, they are in the right side. They are directly drained to the inferior vena cava. In the left side, it's a little bit different, because it's in the left side, the gonadal or testicular or ovarian and the suprarenal vein, they are drained to the left renal vein, and then it drained to the inferior vena cava. So this is the shifting the blood from the left side to the right side. Is the shunt from the left to the right, and it's the left renal vein, the left suprarenal and left gonadal system, and the left common carotid common iliac vein. So those are the tributaries of the inferior vena cava, and there are a little bit difference in the lumbar veins that we are going to discuss. So this is the relation of the inferior vena cava comparing to the abdominal aorta. As you see, that is located in the right side. One of the tributary, they are, you know that they are the hepatic veins, that there are three hepatic veins that they are carrying the blood from the sinusoids and finally to the inferior vena cava, the right, left, and middle hepatic veins. And the inferior vena cava, according to the topography, we have the anterior surface of the inferior vena cava. It has a close relation with the right common iliac, the root of the mesentery, the testicular and ovarian vessels, and the inferior part of the duodenum, pancreas, bile duct. So they have the topography of anatomy that you could see, but what I wanted to mention about the lumbar vein. So there is a different, we know that the abdominal aorta, it gives the parietal branch as a 4 lumbar arteries, paired lumbar arteries, and that's it. But we don't have the ascending lumbar artery. Here we have the ascending lumbar vein in the right side here and in the left side here, which are together with the subcostal. They are making a trunk of the azygos in the right side and hemiazygos in the left side. So this ascending lumbar, they are interconnected with the lumbar veins, and that's why it's the source of the cavo-caval anastomosis, because if you pay attention, the lumbar vein, mostly, they are draining to the inferior vena cava. Of course, the last one is, or the fifth one is draining to the iliolumbar vein. But also the lumbar vein, they are interconnected with the ascending lumbar vein, which is draining to the hemiazygos or azygos vein, which is connected to the superior vena cava. So here you can see one of the very important cavo-caval anastomosis via the lumbar vein to the inferior vena cava and via the ascending lumbar vein through the azygos system to the superior vena cava. So this is the important cavo-caval anastomosis, which is again we are going to mention it. So this is the variation that usually the third and fourth lumbar vein is directly the drain to the inferior vena cava. The first and second they are connected with the ascending lumbar, and the fifth one is connected with the iliolumbar vein. This is the summary of the tributaries of the inferior vena cava according to the parietal and the visceral. The inferior phrenic hepatic veins, that there are 3 suprarenal on the right side, again to the directly to the inferior, in the left side to the renal vein, and then to the inferior vena cava. The renal vein is the visceral, testicular or ovarian, again the same in the right side to the inferior vena cava, left side to the renal vein. Ascending lumbar vein, as we mentioned it, is not a direct tributary, but it's connected with the lumbar vein, that it's the direct tributary, common iliac and median sacral. Those are the tributaries, and again I emphasize that pay attention that in the left side, the left suprarenal and left testicular or ovarian, they are draining to the renal vein and then to the inferior vena cava, but in the right side directly is going to the inferior vena cava. And now, if you understand whole system of the azygos system, or superior vena cava and inferior vena cava, then we can see the region which is called cavo-caval anastomosis. It means through some small vessels and anastomosing of the some small venous connection together, the superior vena cava and inferior vena cava, they are interconnected to each other. One of them is the lighter blue is the tributary of the superior vena cava, the darker blue is the tributary of the inferior vena cava. So if you remember, do you know the superior epigastric arteries branch of what? Anyhow? Anybody? Superior epigastric arteries branch of? Yes? No one? What? No. No. It's not portal system. No. Portal system, portal vein that we are going to discuss, it's collecting the veins or the blood from the unpaired organ of the abdominal cavity. Yes. So except the lower portion of the rectum. Yeah, but here is the wall, and the superior epigastric vein is draining to the internal thoracic vein. Internal thoracic vein, then it draining to the subclavian vein mainly, and then subclavian vein is connected with the internal jugular vein to the brachiocephalic vein and superior vena cava. So this is one way of the passage of the superior vena cava, the superior epigastric to the subclavian, subclavian to the brachiocephalic, and to the superior vena cava. As you see, here is the inferior epigastric. Inferior epigastric vein, it's interconnected with the superior epigastric vein exactly at the region of the rectus abdominis muscle, so under that or behind that. So here there are this anastomosis, the cavo-caval anastomosis, which is the inferior epigastric vein is draining to the external iliac vein, and external iliac vein is going to the common iliac vein to the internal, to the vena cava inferior. So here is one of the place of the junction of the superior epigastric and inferior epigastric, superior epigastric to the superior vena cava, inferior epigastric to the inferior vena cava. So one place of the very important place of the cavo-caval anastomosis, and every student must be able to describe how this connection it happened. The second one that it's the vein, the superficial vein in the anterior thoracic or abdominal wall. So in the thoracic region and abdominal region from upper part, we have two superficial veins. One is the lateral thoracic vein and the other is the thoracoepigastric veins, that they are ultimately, they are draining to the subclavian, and from the subclavian to the brachiocephalic and to the superior vena cava. So this is the way that it's passing to the superior vena cava. But in the abdominal region, especially in the region of the umbilicus, we have another superficial vein which is called superficial epigastric vein. So if you have a whitish skin behind your skin or below the skin, in the subcutaneous tissue, you can see some bluish color, and those are the superficial veins which are called superficial epigastric vein. This superficial epigastric vein, it has another pathway. It's going to the vena saphena magna or great saphenous vein that ultimately is draining to the femoral vein, and femoral vein again to the external, and external to the common, and common to the inferior vena cava. So another important cavo-caval anastomosis is the place that the thoracoepigastric and lateral thoracic vein, they are anastomosing with the superficial epigastric vein. So this is another, the second important way of the cavo-caval anastomosis. And the third one, we already mentioned it here regarding the lumbar and the ascending lumbar. We said that the ascending lumbar vein, they are one of the tributaries of the azygos and hemiazygos, so which is draining ultimately to the superior vena cava in one way. But lumbar veins that they are directly to the drain to the inferior vena cava is connected together. So ascending lumbar and lumbar veins, they are interconnecting together, and it's the third cavo-caval anastomosis. So we have the fourth one, which is in the vertebral plexus happening, which is also is considered, but these three, I suppose that is the most important. So the fourth one is the connection of the vertebral plexus, the venous vertebral plexus, to the superior and inferior vena cava. Sorry. So here, very nice, in this picture you can see, and during the dissection, you can find also those structures. So this is rectus abdominis, and behind the rectus abdominis, you can see this vessel. This is the superior epigastric, which is draining to the internal thoracic and internal thoracic to the subclavian and then to the superior vena cava. So here is the one way. And the other one is the inferior epigastric, which is draining to the external iliac and then to the common and then inferior vena cava. So this is one place of the cavo-caval anastomosis. The other, as we mentioned, is the thoracoepigastric vein. Thoracoepigastric vein superficially is going and also it is interconnected with the lateral thoracic vein here, the lateral thoracic vein, and all of them, they are draining to the finally subclavian, and subclavian to the axillary, and the subclavian to the brachiocephalic and superior vena cava. But near to the umbilical region, you can see another venous superficial veins, which is the superficial epigastric vein here. And as you see, they are interconnected together. The thoracoepigastric and the lateral thoracic veins, they are interconnected with the superficial epigastric vein. But superficial epigastric vein is draining to the exactly at the level of the hiatus of the vena saphena magna, it draining to the greater saphenous or great saphenous vein, and then it's to the femoral, and then to the inferior vena cava. So this is another, and about the ascending lumbar and lumbar we already mentioned. So these three cavo-caval anastomosis. Why we are concerning so much about this venous circulation? Because usually, mainly in the leg region, we have some thrombosis, the deep vein thrombosis, that it can be potentially a fatal condition when the thrombose or the blood clot from the deep venous system of the leg, it's going farther, and it's going to the inferior vena cava, and from the inferior vena cava, this blood clot or thrombosis is entered to the right atrium, and from the right atrium to the left, to the right ventricle, and it's pumping to the pulmonary trunk, and it goes to the lung. It can cause sudden death. So this is important. That's why, and usually, or mostly, because of the non-functional functioning valve of the veins, especially in the lower extremity, that they have to push the blood against the gravitation toward the heart. So those people that they are for a long time, they are inpatient in hospital, inside the hospital, they are laying in, and they have to be in the laying position without any movement. So they are prone to this thrombosis. That's why if you see, they have the bandage of the lower extremity during the surgery, and also those people that they have the contraceptive pills, the ladies, so they are prone, and smoking, and some long time travel by the airplane, so they are the risk for the formation of this thrombose in the vein. So that's why, due to this dysfunction of the valvular system, so you can have the edema of the lower extremity and ulceration that we already mentioned, and we show it to you. Very important chapter that you are familiar with this, and is crucial important, and every student must know about this vein. It's portal vein. Portal vein is carrying the blood, to simplify it, carrying the blood from unpaired organ of the abdominal cavity. What are the unpaired organ of the abdominal cavity? For example, the most part of the digestive tract, large intestine, small intestine, stomach, sigmoid colon, and the upper part of the rectum, not lower part or inferior part of the rectum. Yes, just the upper part of the rectum which is tributary of the inferior mesenteric artery and inferior mesenteric vein, of course. Yes, carrying the blood from pancreas. This blood from the digestive tract, they are full of the nutrition. They are carrying to the portal vein. So that's why this portal vein is considered as a functional blood supply of the liver, because you know that we have the nutritional blood supply of the liver, which is which artery? Yes? Hepatic artery, proper hepatic artery, thank you. But this functional is carrying the blood from the pancreas. What is the content of the blood from pancreas? What it can be? What is producing pancreas except the extra, yes? Insulin, hormones. Yes, insulin, glucagon, they are carried to the liver via the portal vein. Gallbladder, spleen. What is the content of the blood from the spleen? Yes. Old red blood vessels, which is due via the spleen, if they are breakdown, and the breakage of the red blood cell, which is the hemoglobin. So it's the iron and the globulin, so it's carrying to the blood, so to the liver. So all this material, what is the content of the stomach? Maybe you are more familiar with that. When you are drinking alcohol, immediately the blood from the alcohol from the stomach is absorbed into the blood and is carried to the liver for the intoxication of the alcohol. You take the aspirin. Aspirin in the stomach is absorbed and is going and is carried to the liver. So it's very important. Vein, the portal vein. That definitely in the chapter of the liver you have seen and you discussed it. So finally, all this blood, which is contained of the full of the nutrition, contain of the alcohol, contain of the medication, contain of the hormones, contain of the old destruction of the old red blood cell, they are carried by the portal vein to the liver. And the liver is starting to metabolize all wanted material taken, unwanted material is expelled to the three hepatic vein, the left, right, and middle hepatic vein, which is finally is draining to the inferior vena cava, and it goes to the right atrium from the foramen of the inferior vena cava. Yes? So this is the classical and the basic information that every body must know. So I don't want to listen in the final exam somebody come and say that the tributary of the portal vein is renal vein. Is it possible? No. Is it? First of all, is paired organ, and renal vein is draining to the inferior vena cava. Yes, is a basic, but I don't know, most often I hear that is. Testicular or ovarian doesn't go to the portal vein. We don't need. So it's going to the inferior vena cava directly or indirectly from the right or left side. Yes? So pay attention to this thing. Why the content of this blood must go to the liver. So nutrition, we need it. The liver is absorbed. So alcohol, we don't need it. It must be intoxication to the liver. Hormones, glucagon, insulin, you need it for the synthesis of the glucose and glycogen. Yes? And the red blood cell, hemoglobin, and iron, so destruction, it's for formation of the bile system. Yeah? So all this thing is important to understand. Yes? Now, what is the portal vein? Portal vein is formed by the union of the two main veins. One is a splenic vein, the other is superior mesenteric vein. These two veins, they are exactly behind the neck of the pancreas. They join together. So it means that when you are dissecting the cadaver and you find the pancreas and you dissect the pancreas, you know that behind the neck of the pancreas, you have to find the place that the splenic vein and the superior mesenteric vein, they are union together and junction together, and they make the trunk of the portal vein here. Yes? Of course, you can see another very big vein here, which is called inferior mesenteric vein. And inferior mesenteric vein, again, what I said in the first, inferior mesenteric vein usually is draining to the splenic vein, but you can see, maybe in dissection in this year, you can see that it's going and it's draining to the superior mesenteric, or is draining in the junction of the splenic and the superior mesenteric. There is a variation, but usual place is that inferior mesenteric is draining to the splenic vein, yes? So two main trunk that definitely you have to mention it in the exam is the splenic and the superior mesenteric, and the inferior mesenteric either to the splenic or to the superior mesenteric or the junction of both of them. So this is the explanation that I said, that the splenic nerve, splenic vein behind the neck of the pancreas is joining with the superior mesenteric, and then it's making a trunk, a short trunk of the, but the caliber or the diameter is so big, and it's entered to the hilus of the liver, and immediately after the entering of the hilus of the liver is divided to the right and left hepatic, portal hepatic branches, which is continue as a sinusoid. You know that is giving to the smaller branches, and the sinusoid is going toward the central vein, and central vein is collecting the venous blood supply and going to the hepatic vein, and from hepatic vein to the inferior vena cava. So that you know it in the liver chapter. So this is the how and the basic information that every student must know, yes? Then, when you know that, is exactly when you have the information of the artery, blood supply, and the branches of the superior mesenteric vein, and the splenic vein, and inferior mesenteric, artery. So exactly is the same name in most of the case, 95%. It's the same name and tributary for the superior mesenteric vein, so which is draining to the portal vein. Is exactly all the branch of the splenic artery that you know. The synonym is for the vein that is going to the splenic and it goes to the portal vein. And also the inferior mesenteric, which is the superior rectal, the sigmoid, and the left colic veins that they are. Is similar to the artery of the inferior mesenteric, yes? So there are some few veins that they are directly open to the trunk of the portal vein. One of them is gastric veins. Gastric veins, it's left and right gastric veins that they are draining the lesser curvature of the stomach, and it doesn't go to the splenic, doesn't go to the superior mesenteric, doesn't go to the inferior mesenteric, but it goes directly to the portal vein. Another is the cystic. From the gallbladder, cystic vein is open to the trunk of the portal vein, and another vein which is parallel with the round ligament of the liver or ligamentum teres hepatis is the paraumbilical vein. It's paraumbilical vein which is this ligamentum teres or round ligament of the liver is connecting the anterior aspect of the liver to the liver to the anterior abdominal wall, that we need this information in a while for the portocaval caval anastomosis. Yes, so if you know the tributaries of if you know the branches of the superior mesenteric artery, splenic artery, inferior mesenteric artery, the synonymous is the tributaries of in most of the case, of course, except these things that I said, it's the tributary of these veins to the portal vein, yes? And this is the relation. You see that we cut the neck of the pancreas, and you can see the union of these two major trunk for the portal vein, and portal vein is going upward in this region. So right, left gastric vein, cystic vein, paraumbilical vein, they are the direct tributaries that they are going to the portal vein, and indirect, the main common is the splenic and superior mesenteric. So here, for the recapitulation, I have it for you. The tributaries directly to the splenic vein, short gastric, left gastroomental, pancreatic, and usually we said that inferior mesenteric, which is draining to the splenic, yes? And regarding the superior mesenteric, which is carrying the blood from the small intestine, cecum, appendix, ascending colon, and transverse colon, is the synonym, as we said, the branches, the middle colic, right colic, right gastroomental, anterior, posterior, inferior pancreaticoduodenal, and the superior pancreaticoduodenal vein, all to the distinct. So those all branches of the artery and the veins, they are the synonym together. Inferior mesenteric, as we mentioned it, and you need it for the portocaval anastomosis in a while, is carrying the blood from, be careful, superior part of the rectum, only superior, because the superior rectal vein is draining to the inferior mesenteric, then is continue the sigmoid and left colic, and it's draining to the portal vein. Yes, so have this information, and now we reach to the very important chapter, which is called portocaval anastomosis. Yes, portocaval anastomosis, it's happening that there is a small veins that you had the cavocaval anastomosis. You have the small veins that in that area, or the regions that in that area, there are located some small veins that in one way, they are connected to the portal vein via superior mesenteric, inferior mesenteric, splenic, or direct portal vein. And in other way, they are connecting with the either superior vena cava or inferior vena cava. Yes? So that's why they call it portocaval anastomosis. Yes? One side is portal vein, the other side is either superior vena cava or inferior vena cava. So three places, they are crucial important. There are more places, there are approximately 6, but 3 of them, they are very, very important, and every student must be able to explain this portocaval anastomosis in this region. One is around the inferior end of the esophagus. The other is around the inferior part of the rectum, middle and inferior part of the rectum. And the other is around the umbilical region. Yes. So this 3 region is crucial, important. That is important. So why is inferior end of the esophagus? Because inferior end of the esophagus, the esophageal vein, if you remember, they are the tributary, the upper part, they are the tributary of azygos system. Yes. So these veins in this area, somehow they are draining to the azygos system to the superior vena cava. Yes. But left gastric vein, it's draining to the, or gastric vein generally, mainly left gastric vein, it's draining to the portal vein. And this left gastric, it has some esophageal vein branches, yes, which is interconnected with the esophageal branches that they are draining to the azygos system. So that's why this region is called portal vein, caval anastomosis. This is one region. Here in the rectum, inferior part of rectum, we said that superior rectal vein is draining to the inferior mesenteric vein, and then ultimately to the mainly splenic, let's say, and then to the portal vein. Yes, so all this drainage of the upper part of the rectum is going to the portal vein. But middle part and inferior part of the rectum, the drainage, it goes to middle rectal vein, it drains to, you know, middle rectal vein, it drains to yes, internal iliac vein directly. Inferior rectal vein, it drains to internal pudendal vein, then to the internal iliac vein, then to the common iliac vein, then to the inferior vena cava. So in rectum, so here the middle and inferior part, they are draining to the internal iliac to common iliac to the inferior vena cava, but superior part is connected via the inferior mesenteric to the portal vein. So the superior and middle and inferior, they are the veins, they are anastomosing together. So they are portocaval anastomosis here, and this is one of the reasons that if the liver doesn't function in well, so is one of the reasons of the hemorrhoid. So we have the external and internal hemorrhoid, and the patient will have the bleeding during to the defecation that he has. So this is extremely important, yes, because the third one is the paraumbilical vein. So the paraumbilical vein, which is draining directly to the portal vein, the accompany with the ligamentum teres or round ligament of the liver, and we said that around the umbilical region we had some superficial vein here. What was the name? We needed for the cavocaval anastomosis also. Yes? Yes. Superficial epigastric vein, for example. Yes, perfect. And upward it was the thoracoepigastric vein. So the superficial epigastric. So those are the veins that the superficial epigastric goes to the vena saphena magna or great saphenous vein, femoral, then external iliac, then inferior vena cava, but it has interconnected with the paraumbilical vein, which is draining to the portal vein. Yes? What is the consequence? Yes? Yes, here is caput medusa. Yes. What is it? Why it happening? Why we need this portal vein? Why we need this anastomosic? Yes? Yes. Yes, exactly. So let's say in the normal condition, the portal vein is carrying the blood from the digestive tract full of nutrition. From the spleen, the destruction of the red blood cell. From pancreas, the hormones. From the stomach, aspirin, alcohol. From gallbladder, the content of the bile. Yes? So they are carrying, and it give it to the blood, to the liver. The liver is healthy, very nice, is metabolism, everything, intoxication, all wanted material is taken, and unwanted material give it to the hepatic vein, to the inferior vena cava, expel. Yes? What happening if the liver become diseased, damaged? Yes? Typically alcoholic people. So you know that alcoholic people, they have liver cirrhosis, so the liver function is not. The problem is not only liver, it can be some problem with the vessels, perihepatic, it means before the liver. Mainly is the liver inside and after, because the hepatic vein, they cannot carry it, give it back to them. Yes? So if these three reasons or any reason that the portal vein cannot give the content to the liver because the liver is not well, so the portal vein doesn't know. He wants to give it to liver, but liver is rejecting it. Yes? He doesn't want because he is sick. He cannot handle it. So portal vein give it, he doesn't want. Give it, he doesn't want. What will happen is increasing the pressure happening here. So it's called portal hypertension. So the increasing of the pressure by the portal vein, if it doesn't have a way to release this pressure, so this portal vein is ruptured and it will be a bleeding. But thanks to the portocaval anastomosis, so this pressure that he wants to give it to the liver doesn't accept it, it's going back. So there is a big pressure here, and this pressure must be released. How it will be released is going here, is going to the inferior mesenteric, is going to the rectum, which is superior and middle and inferior rectal veins, they are anastomosing together and is going to the inferior vena cava, is released, the blood, yes? And the pressure is going down. So, and what happened? This small vein is becoming dilated, tortuous, and rupture, and it's, in the case, it's called hemorrhoid. This is not a big issue. The most important issue, or here that we said, the hypertension happened, the pressure is going to the paraumbilical to the umbilical region. It has connected with the superficial epigastric veins, the small veins around the umbilicus, and they become dilated. So those people that they have a liver disease, if you look at it, so you see that there is a hair, the snake-like hair of the witches that is called caput medusa, yes? The caput medusa is the dilatation of the vein around the umbilicus, which is tortuous and is making a snake hair of the witches in the history. So this is the caput medusa. But also this is not a big issue. It is important, but very important, the most important one is this part, yes? This part that the portal hypertension is happening and the pressure it goes to the gastric vein to the esophageal branches, and this esophageal, they are interconnected with the esophageal branch that they are going to the azygos system, yes? And this vein in the inferior end of the esophagus is become dilated, 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 and in the severe case, if it ruptured, no one can stop this bleeding. The patient will die. Or, let's say, the patient, it goes under a gastroscopy, yes? The camera, it goes through the esophagus and they go to the stomach to see if there is ulcer or something like this. If the doctor doesn't aware about this thing, with the touching of this vein, the vein is ruptured and it causes bleeding. So yes, this is the importance. So these three, please pay attention. The place is the portocaval anastomosis, and this is clinically very important, and you need it for higher year and higher year in surgery, internal medicine, and so on. Yes, so this is, as a matter of fact, this is the recapitulation of what I say, and another three other place of the portocaval anastomosis is the bare area of the liver, is a small part of the liver which is not covered by the peritoneum, is covered by the diaphragm. This is a part of the portocaval anastomosis, retroperitoneal area of the large and small intestine, for example, ascending colon and descending colon, and some small part of the duodenum, which is retroperitoneally is located, the posterior surface of the pancreas, which is the secondary retroperitoneal organ. These are another three portocaval anastomosis, which is the first one. It was the esophageal, rectal, and caput medusa. They are the most important that definitely you have to know about this matter. And this is the hemorrhoid that I mentioned it via the superior part of the superior rectal vein, middle rectal vein, and inferior rectal vein. The superior one is draining to the inferior mesenteric, to the portal system, and the middle and inferior via the internal pudendal and internal iliac, it's going to the caval system, the inferior vena cava. So in the case of the liver disease, so those veins, they become dilated. So this dilatation inside is the internal rectal plexus, which is located between the internal anal sphincter and the mucous membrane, that lining of this, and it is above the pectinate line is happening. This is called internal hemorrhoid, and external hemorrhoids is located subcutaneously between under the skin and external anal sphincter. So those are the hemorrhoids that we have, the plexus hemorrhoidalis internus and externus that we already mentioned it. And here again, recapitulation of those structure that is said, rectum, esophagus, and caput medusa here with another picture for better understanding of this thing. And back to the cross-section and position of the portal vein. We said that the formation of the portal vein, formation of the portal vein happening behind the neck of the pancreas, and then the portal vein is passing through the, do you know which ligament? Is one of the ligament of the lesser omentum. Gastroduodenal, thank you. Inside the gastroduodenal ligament, you can find three structures, which is called porta hepatis. Portal vein is located in the posterior aspect. Remember, portal vein in gastroduodenal ligament. Hepatoduodenal. You said hepatoduodenal or gastro? Hepatoduodenal ligament. In the hepatoduodenal ligament, it's located posteriorly. Anteriorly and on the left side is the proper hepatic artery, and anteriorly in the right side is the bile duct, common bile duct. So this is, pay attention to the position that when you are going to dissect and you find the hepatoduodenal, not gastroduodenal, hepatoduodenal ligament. So you cut the hepatoduodenal ligament and you know that posterior to these two, proper hepatic and bile duct, is portal vein. So you can find this portal vein. And the other organs that you can see. This lecture is too long. Do you want some break or shall I continue? Yes? Continue? Continue. Break? 5 seconds is enough? Okay, 7 minutes? 9:30, yes? Okay. So regarding the veins of the pelvic region, to understand the veins of the pelvic region, so more or less the pelvic vein, they are following the course of the all branch of the internal iliac artery, except two veins. One is iliolumbar artery, it means iliolumbar vein that we discussed it in the lumbar region, and also the umbilical vein, which is paraumbilical vein, and also we discussed it. So generally in the pelvic cavity, the venous system around the organs, they are making a plexus. We don't have one single artery that it's, for example, for the internal pudendal, for the rectum, for the vesical, superior vesical, inferior vesical artery, but around the viscera or around the organs, the veins in the pelvic region, they are making plexuses. And these plexuses, they are around the bladder, so they called vesical plexus. Around the rectum, we discussed it, the superior, middle, and rectal and inferior rectal, they are making a rectal plexus. Around the prostate, it's the prostatic plexus, and uterus and vagina plexus in the female. What is important is that the vein, for example, in the rectum, that you can see that we mentioned it, this middle rectal vein, which is directly draining to the internal iliac vein, and it draining to the inferior vena cava further. This is connecting with the inferior rectal vein, which is draining to the internal pudendal vein. So here is the internal pudendal vein, which is going, and it has a connection here, which is then finally draining to the internal iliac vein, and then it's to the inferior vena cava. So this is one thing, and the other one is the one single deep dorsal vein of the penis, which is in the erectile or clitoris, of course, which is draining the erectile part of the penis or clitoris. It doesn't follow the internal pudendal artery, because those arteries, they are normally a branch of internal pudendal artery, but in the male, it's draining to the prostatic plexus, and in the female, it's draining to the vesical or bladder plexus. And this is the recapitulation what I said about the veins. More or less is following the artery of the internal iliac artery, and in the organs they are making a plexus, which you have a table here. Again, I mentioned it, gonadal veins, it means the testicular and the ovarian veins, they are following the same way of the artery, but the drainage is different. In the right side to the inferior vena cava, in the left side to the renal vein. Again, we discussed it about this matter. So, very important chapter is the veins of the lower limb, or generally the veins of the limbs. That you need this information also during the dissection, because you have to find those, at least these superficial veins, that is important, and already I suppose that you have seen it in dissection during the practical. Generally, the veins of the limbs, the upper or lower limb together, we divide to two main groups, the superficial vein and the deep vein. What about the deep vein? And regarding the deep veins, they are generally following the same course of the artery. So if you have it in the lower limb, the femoral, the popliteal, the anterior and posterior tibial and fibular artery, so you have parallel with them also the same name veins. Yes? So it means that if you study the artery, so more or less that you know the deep vein of the venous drainage of the lower limb. Yes? But the problem appears, or not the problem, but some interesting thing is appear when in the superficial vein it's occur. The superficial vein of the lower limb, they are located in the subcutaneous connective tissue. That's why be careful during the dissection. When you are cutting the skin, be careful not so much press the scalpel, because then you can't cut the superficial structure, which are usually accompanied with the cutaneous or sensitive nerves that they are innervating the skin. Yes? So they are located in the subcutaneous connective tissue. And very important, remember that superficial veins, they are interconnected with the deep vein via specific veins which are called perforating veins. So remember that always superficial vein, they are interconnected with these deep veins that we mentioned it, the anterior, posterior, tibial, popliteal, femoral, superior gluteal, inferior gluteal obturator. So they are interconnected together that we are going to discuss. Two main superficial veins, we have it in the lower limb. One is great saphenous vein, which is originated on the medial side of the dorsum venous arch here. Here in the dorsum of the foot, there is a network of the venous plexus. And from this network of the venous plexus, from the medial aspect, it's arising the great saphenous vein. Remember the great saphenous vein, the Latin name is vena saphena magna. Yes. So it's arising and is going upward in the medial side of the leg, and then it's going upward until under the inguinal ligament in the opening, which is called saphenous hiatus, or hiatus of the saphenous vein, or the saphenous opening, and it drains to the femoral vein, just inferior to the inguinal ligament. The other superficial vein is originated from the lateral side of the dorsal venous arch, and it's going in the posterior surface of the leg. Definitely you have seen it in dissection, that in the posterior aspect is going upward and is penetrating the fascia and is draining to the popliteal vein, in this region under posterior to the knee joint. So then, of course, the popliteal vein, then it's penetrating and is going to the adductor hiatus from the adductor magnus, and it continues as a femoral vein. So this is a general view about the venous system of the lower limb, and I mentioned about the perforating vein. The perforating vein, or vena perforantes, that they are interconnecting the superficial vein with the deep vein of the body, and they are clinically, they are very important, because if something wrong happening to this perforating vein and the valve of this perforating vein, so then you can see that the varicosis or varices of this small superficial vein, it can happen because the pressure is going back from the deep, the blood is going back from the deep to the superficial, and this superficial vein, they are increased by the pressure and they are dilated and tortuous. Usually in pregnant women it can happen, and they destroy this valvular system. And sometimes is necessary to do the excision and stripping of this vein, the vena saphena magna or vena saphena parva. And you see that the skin is pigmented. So this is the vena perforantes. The vena saphena magna, or the great saphenous vein, as we mentioned, that is in the medial aspect of the leg, is going upward. Under the inguinal ligament, here there is a saphenous opening, or saphenous hiatus, is penetrating this fascia in anterior aspect of the thigh, is called fascia lata. So it's perforating the fascia lata, so it means that it's draining in the deep vein, which is the femoral vein here. So the great saphenous vein in this region, when it's draining to the femoral vein, is receiving another veins that some of them already you know it. So one of them that is perforating veins because connecting to the deep vein. The other is accessory saphenous vein that you will see it in the dissection. External pudendal, that is from the external genitals, they are draining here. Superficial epigastric, we mentioned it is one of the cavo-caval anastomosis and portocaval anastomosis, which is draining to the vena saphena magna, and also the superficial circumflex iliac vein. As a matter of fact, is a branch of the external iliac artery, so it's the branches of the femoral vein, so it's draining to the vena saphena magna, and then it's to the femoral vein. So this femoral vein is very important because the access of this femoral vein is important for the insertion of the catheter, and through this femoral vein you can go to the renal vein, to the gonadal vein, to the right atrium, and to the right side of the heart. So this is also clinically is important for this matter. And here you can see the course of the vena saphena magna, that is penetrating this hiatus. Here you can see the popliteal vein. The femoral vein, as you see, here is the femoral vein. This femoral vein, if you go it in the beginning, so it's a popliteal vein because the vein is vice versa of the artery. So you have the femoral artery, then it goes through this hiatus, which is called adductor hiatus of the adductor magnus muscle, and then it's going as a popliteal in the backside of the thigh. But for the vein, if you explain, you have to go it vice versa. It means first is popliteal vein, which is going to the adductor hiatus, and it's continue as a femoral vein, which is under the inguinal ligament. There is receiving the vena saphena magna or great saphenous vein. Here in this popliteal region, you can see a very important superficial nerve, which is accompanied with the another superficial vein, which is called vena saphena parva, or a small saphenous vein. Yes. So remember two things: greater saphenous or great saphenous vein, or vena saphena magna, which is going in the medial aspect of the lower limb. It's somehow they have the same course of the, in most of the course, they have the same course of the sensitive nerve branch of the femoral nerve, which is called saphenous nerve. Yes? So great saphenous vein and saphenous nerve together. Yes, branch. This is cutaneous nerve sensitive innervation. The small saphenous vein, which is here, in this region, in a while I will tell you, and sural nerve in the back side of the leg, they have the same course together. Yes? So small saphenous vein, sural nerve, great saphenous vein, saphenous nerve. Here we said that the great saphenous vein, or vena saphena magna, in medial side is turning and then is going upward to the femoral. Here is the vena saphena parva, or small, is going backside. One important information: great saphenous vein is going in front or anterior to the medial ankle. Yes, we said it in the dissection. So great saphenous vein is in anterior to the, is not retromalleolar region, anterior to the medial ankle, and then in the medial aspect is going on. But the small saphenous vein, or the lesser, or the vena saphena parva, is going behind the lateral ankle, and then is posteriorly is going and is draining to the popliteal vein, and it has the passage together with the sural nerve. Here is passage with the saphenous nerve. And here is the region of the popliteal fossa. This is the insertion of the biceps femoris to the head of the fibula, and here is the semitendinosus and semimembranosus, and here is the gastrocnemius muscle. So there is making a rhomboid fossa, which is the popliteal fossa, and the most superficial is tibial nerve, and then is popliteal vein, which is in the middle after the nerve, and most deepest structure is the popliteal artery. And here it's the passage of the vena saphena parva, or a small saphenous vein, in the backside of the leg, which is perforating the deep fascia, and then is going deep and it's draining to the popliteal vein. So vena saphena parva is drained to the popliteal vein. And here is another branch of the sciatic nerve, which is the common peroneal nerve, which is going and is divided to the superficial and deep peroneal or fibular nerve. Here you can see a cutaneous nerve, which is called posterior cutaneous nerve of the thigh, or nervus cutaneus femoris posterior, is directly coming from the sacral plexus, and here is making a branch around this posterior aspect of the thigh and popliteal region. And here you can see the sciatic, which is divided to the tibial and common peroneal, then is popliteal, and then is artery. And here is the famous structure, the medial retromalleolar region, that if you remember, we have a formula here, which is TD1H or TD1H. The first is the tibialis posterior, then is the flexor. Remember flexor, the posterior group, they are flexors. So flexor digitorum longus, and here you can see, I said that in periphery, you have one artery which is always accompanied with two veins. You see one, so is vein, two vein, and artery and nerve. So there are the posterior tibial vessels, or artery and veins, and then the tibial nerves, and the last one, or H or H, is the flexor hallucis longus. So remember, those are the structure that they are behind the medial ankle, so it means that medial retromalleolar region. So this is important to know TD1H or TD1H, or whatever that you want to say, but you have to know. And this is the originated of the vena saphena magna and parva that is coming from the arch of the dorsum of the foot and the plexus of the dorsum of the foot, which is carrying the metatarsal veins and digitorum veins, the proper and digital veins, which is draining to this arch. And in the medial side, vena saphena magna, and in the lateral side, the vena saphena parva, it's passing. So this is the same things. And this is the thing that I mentioned. The great saphenous vein is passing anterior to the medial malleolus, anterior to the medial ankle. So it doesn't go behind the medial ankle. So you can, when you dissect it, it's anteriorly is passing and it's going upward medially, but the small saphenous vein or vena saphena parva is going behind the lateral malleolus and or lateral ankle, and it's going backside together with the sural nerve. And this is the illustration of the origin of the these two saphenous, and this is the place of the drainage of the great saphenous and drainage of the small saphenous to the popliteal, and here is the femoral vein. Veins of the upper limb, the same pattern of the lower limb. So the veins of the upper limb also, we divide them to the superficial and deep group. Again, the deep vein, they are following the course of the, or the copying the course of the artery, and usually they are double, yes? It means that we have paired ulnar vein, radial vein, interosseous vein in the forearm region. In the arm region, we have two paired brachial vein in the upper arm, and then it continues as a one axillary vein. Superficial vein, they have different course than artery. We don't have arteria saphena magna, arteria saphena parva, so that's why we don't have also the cephalic and basilic artery. We have superficial veins, which are called the most important, the cephalic, basilic, and median cubital veins. As we mentioned it, they are located in the subcutaneous connective tissue. The lateral side, it's the cephalic vein, is originated from the venous plexus in the dorsum of the hand, the same that you had it in the dorsum of the foot. Here is dorsum of the hand. In the left side, in the lateral side, from the dorsum of the hand, from the snuff box place, it's originated the cephalic vein. You go anterolaterally, it's going to the cubital region. It's connected with the second one, which is called the basilic vein. They make the median cubital veins here that we discussed. It's going upward to the arm region, and it's going to the place which is called, it is the groove between the deltoid muscle and pectoralis major. That's why this groove is called deltopectoral groove, or that there is a triangle they call deltopectoral triangle or cleft. And here is, again, the superficial vein, they are interconnected with the deep vein. So it must be piercing the deep fascia, and this fascia which is here is the clavipectoral fascia, and under the clavicle, and then is piercing this fascia, then it drains to the axillary vein. So this is the course of the cephalic vein that you can see. The basilic vein is starting from the dorsum of the network of the venous system of the hand, and it's continue medially in the forearm region, and near to the cubital region, it's turning to the anterior side, and here is piercing the fascia again. Here, by the piercing of the fascia, it will be accompanied with the cutaneous nerve, which is the medial cutaneous nerve of the forearm, and then it's continue as a axillary vein here. Yes. So in some literature, you see that they write the basilic vein, it's draining to the brachial vein, but in Gray's anatomy, that is our reference, the basilic vein is continue as a axillary vein, and the brachial vein either is draining to the basilic vein or directly to the axillary vein. So those are the important. And here there is another superficial vein which is called median cubital vein. This is the vein that usually if you want to make some blood sample from the patient, so you see it under the skin, and we are going to discuss. They have different variation, like a W, like a M, like a V, or separate from each other, but the name is median cubital vein. Regarding the axillary vein, to recognize where is the axillary vein and where is subclavian vein and where is the brachial vein. This is the important. The axillary vein is starting from the lower margin of the tres major. So from the tres major, it's starting the axillary vein and it's going till the lateral aspect of the first rib. So here is finishing the axillary vein, and the name is becoming subclavian vein. Yes. So subclavian vein originated or starting from the lateral aspect of the first rib. Another very important thing about the subclavian vein is, as you see, subclavian artery is passing through the scalenic fissure. If you remember scalenic fissure, it's the fissure, extremely important, is the fissure between the anterior scalene and medial scalene muscle. Yes, and between these two muscles, anterior and medial scalene muscle, there is a fissure which is subclavian artery together with the brachial plexus that in the nervous system we are going to discuss. It passed through this fissure, but subclavian vein is anterior to the scalenic muscle, anterior scalenic muscle. It doesn't pass through the fissure. Yes, this is the topographical relationship of these two veins, and usually is a matter of the question in final exam. Yes, so be careful of the position of the vein. Vein is anterior to the anterior scalene muscle, so it means that it doesn't pass through the scalenic fissure, but artery, the subclavian artery and brachial plexus, they are the content of the scalenic fissure between the anterior and medial scalenic fissure. Muscle. So this is the things, and here you can see the continuation of the basilic vein that we said that is piercing the deep fascia and continue as an axillary, and there are two small brachial vein that they are accompanied with the brachial artery, and here we said that either is draining to the basilic and continue as a axillary or directly is going to the axillary vein. So this is the things that I wanted to tell you, and this is the structure that we already said, the posterior circumflex scapula and the posterior circumflex humeral vein, the same course of the artery. This is the clavipectoral fascia that I mentioned, that the cephalic vein, after it passed through the groove between the deltoid muscle and the pectoralis major. So in dissection, if you want to find the cephalic vein, you find the deltoid, you find pectoralis major. So between them there is a groove, and here is the passage of the cephalic vein. Definitely you will find it. Yes, under the skin you will find it. If you know how, if you have the knowledge or theoretical knowledge, then to find the preparation is easy for you. Yes, then when it reach here in this level, it's piercing this clavipectoral fascia, and then it's going and it draining to the axillary vein. Through this clavipectoral fascia, another structure also they are passing. One of them is the lateral pectoral nerve, which is piercing also this fascia, and the other one is the branches of the thoracoacromial artery, which is penetrating this fascia. So those are the structure that is perforating this fascia. The cephalic vein, the lateral pectoral nerve and the thoracoacromial artery, the branches of the thoracoacromial artery, specifically the thoracic branches and other branches also. So here. Here is the origin, is the place of the origin of the cephalic vein and the basilic vein, as I mentioned, from the dorsal network of the back of the hand. The cephalic vein is starting from this anatomical snuff box. Yes. Do you know the tendon here? Those tendons? Muscle. Which muscle is here? Yes? Yes? Extensor? The extensor pollicis longus and perfect. So here is going, and the cephalic vein, we said that the course is in the anterolateral aspect till here to the axillary. The basilic is coming from the medial side of the dorsum venous network, and then it's going posteromedially. Yes? Here the cephalic is anterolateral surface, and here is the posteromedial surface in the beginning, and approximately under the cubital region or elbow region, then it's turning to the anterior side and is piercing the deep fascia about midway of the way of the upper arm. So the brachial region. And the basilic vein that I said that is piercing is the deep fascia. It's going accompanied with the median cutaneous nerve of the forearm. So at that region that is piercing the deep fascia, there is this cutaneous nerve that is coming from the brachial plexus. And here is the interconnection of the cephalic and the basilic, which is called median cubital vein, that it's important, and it's important for the taking of the blood sample, and it has several variations that I will show you. Here in this region we have lateral cutaneous nerve of the forearm, which is the branch of the musculocutaneous nerve that is going in some course with the same name, with the same course of the cephalic vein in this cubital region and some part of the small region. So this is the dorsum, the network of the venous plexus in the dorsum and in the palmar surface. And this is the continuation of the cephalic and basilic vein. And this is the picture that we already we show it to you, that how the basilic vein is piercing the deep fascia in this region, and in anatomical aspect of the median cubital vein, you see that they are different in different individuals. Yes. So there is one vein here which is called deep median cubital vein, which is making as a perforating vein, which is connecting not only basilic and cephalic together in most of the case, but connecting these two superficial to the deep veins in the cubital region as a perforating or deep median cubital vein. Here is the deep median cubital vein in this region, and here is called perforating vein. And this is also very important topographical information that the nervus cutaneus antebrachii-medialis here, or the median cutaneous nerve of the forearm, is together with the basilic after the piercing of the fascia, basilic vein. And here in this region, the cephalic vein is accompanied with the vena nervus cutaneus antebrachii-lateralis, or lateral cutaneous nerve of the forearm. Branch of musculocutaneus is to cephalus with the cephalic vein. And radial nerve here, you can see that it passes its supinator muscle, which is divided to the deep branch and superficial branch of the radial nerve. You will see it in the nervous system. Here is the median nerve, which is accompanied with the brachial artery, which is divided to the ulnar and radial artery. And here is the ulnar nerve that is going to the groove for the ulnar nerve in the medial epicondyle here. So this picture is very important picture, and it has information when you want to dissect this region, so you have to be careful of all this structure. Clinical importance for the subclavian and axillary is a usual place for the access, the central venous access, is a place for the catheterization, and is a place for the insertion of the pacemaker wire if they want to enter to the atrium, so they do it by this access, the subclavian or axillary venous access. They write it subclavian access, but is, as a matter of fact, is the end of the axillary matter. Regarding to the face region, which is our last chapter, and neck region, the main venous system of the face, it's the fascial vein. This fascial vein is starting at the medial corner of the eye orbit as an angular vein, and from the angular vein is going down. It has the same course of the fascial artery, usually posterior to the fascial artery, is going to the body of the mandible, and then it draining usually to the internal jugular vein. Usually you have to pay attention. There is 3 differences between the fascial vein and fascial artery. Fascial artery, usually when you are dissecting, the fascial artery is zigzag, is curvy, is zigzag, is going through the course. This is one. And the fascial vein usually is straightforward. Yes, this is one. Second, fascial vein is posterior to the fascial artery, as you see. Third, which is very important clinically when we are operating the submandibular gland, fascial vein is superficial to submandibular gland, but fascial artery is deep to the submandibular gland. This is one, the three difference. Then another important is the transverse fascial artery and vein. The vein is draining to the superficial temporal vein, which is a component for the formation of the retromandibular vein after the joining with the maxillary. This is the important, two important, and they are parallel and above the parotid duct. So if you find the parotid duct, above the parotid duct parallel with the course, you can find these transverse fascial vessels that they are embedded inside the substance of the parotid gland. In the head and neck lecture, I mentioned about the communication of the veins of the face. If you remember, I said about the danger triangle of the face, upper lip, nose, and this area, that it's very important for the spread of the infection. So if somebody has pimples, don't make the pressure, because the infection, it goes to this venous system, and then it can, thanks to the connection with the intracranial system, so it can cause the severe complication. So the reason is that in the face region, the veins, they don't have valve. So they can go in both directions, to the cranial direction and to vice versa direction. So this is very important for the spread of infection, and the interconnection of them is the supraorbital, supratrochlear vein with the angular with the fascial, fascial with the superior ophthalmic, or the supraorbital to the superior ophthalmic to the cavernous sinus, ophthalmic vein, the inferior ophthalmic vein to the pterygoid venous plexus, via the infraorbital vein to the pterygoid venous plexus. Then pterygoid venous plexus had the communication with the cavernous sinus through the emissary vein, which is passing through which foramen? Perfect. Foramen ovale, that it's the main source for the spreading of the infection from the pterygoid venous plexus in the infratemporal fossa and pterygopalatine fossa to the cavernous sinus. And of course, the fascial vein It has a deep fascial vein, which is not similar with the artery. We don't have deep fascial artery. We have the deep fascial vein, which is connect the fascial vein to the pterygoid venous plexus. So all this together, they are interconnected together, and is important for the spread of infection in teeth, nose, sinus, anything in the orofacial region, and not only infection but also metastatic cells. So any tumor can spread it, and it can cause brain metastatic tumor, which is then usually unoperable. Regarding the ophthalmic veins, you know from the skull that we have two ophthalmic veins, superior ophthalmic veins, that they are passing through the supraorbital fissure, and it drains to the cavernous sinus. And the other is the inferior ophthalmic vein, which is passing through the inferior orbital fissure, and it usually drains to the pterygoid venous plexus. But the superior and inferior ophthalmic vein, they have connection between themselves. So they have interconnection between themselves. Or the inferior, it goes to the pterygoid venous plexus, and through this foramen ovale, or sometimes they write it foramen lacerum, or sometimes they write it sphenopalatine foramen, they are connected with the superior and the cavernous sinus. So this is also important for interconnection of the veins of the orbit. In infratemporal fossa and pterygopalatine fossa, you have a network of the vein which is called pterygoid venous plexus, and is usually located between the medial and lateral pterygoid muscle and temporalis muscle and lateral pterygoid muscle. So here, if you want to imagine the pterygoid venous plexus is the synonym of the all branch of maxillary artery. Yes? So if you consider, if you know the branches of maxillary artery, one by one they give the branches, but in the venous system they don't make the branches, but all together they make a network and plexus, which is called pterygoid venous plexus. So pterygoid venous plexus, very important, it drains via one or two maxillary vein, and it's together is joining with the superficial temporal vein, and they make the retromandibular vein. So retromandibular vein, as a matter of fact, is a superficial vein which is passing through the component of the parotid gland. I have mentioned it also in the orofacial lecture. And it's formed by the union of the maxillary vein and superficial temporal vein. And this, the retromandibular vein, then after passing through the parotid gland behind the mandible, so then it's divided to two divisions. One division is posterior division, and the other is anterior division. The posterior division, it's going to form together with the posterior auricular vein, the external jugular vein. The anterior division is joining to the fascial, and they make the common fascial vein, which is draining to the internal jugular vein. So this is an important part of the venous pathway. About the scalp, you had a lecture, and you have the blood supply, and this is just recapitulation for the blood supply and venous drainage of the scalp in the neurocranial region. Supratrochlear, supraorbital, superficial temporal, posterior auricular, and occipital veins. They are the veins that they are participating for the venous drainage of the scalp. And this is the venous plexus. Then we go to the neck region, which is the last chapter of the lecture. And again, in the neck region, we have deep vein and superficial vein. Superficial vein of the neck region, we have external, that already we mentioned it, is external jugular vein. And also we have the anterior jugular vein. Those are the two main vein, the superficial vein that we have it in the neck region. External jugular vein, as I said, that is formed by the union of the posterior division of the retromandibular. Retromandibular itself, is formed by the union of the superficial temporal and maxillary. The posterior division is joining with the posterior auricular. In some literature, they write it also occipital vein. Also, they can reach to that. And the external jugular vein, if you want to find it, one of the items that you have to find it in the dissection, you find the sternocleidomastoid muscle is the huge muscle in the neck, yes. And under the skin, on the superficial fascia of the sternocleidomastoid, you can see that external jugular vein. If somebody has a thin skin and whitish skin, you can see the bluish color in the neck region. So this is the external jugular vein, which is vertically is crossing and is going over the sternocleidomastoid. And then when it's going descending down in the posterior aspect of the sternocleidomastoid muscle, it's piercing the deep fascia, and then finally it draining to the subclavian. Again, the drainage is different. Some literature subclavian, some literature internal jugular vein, some literature the junction of both of them. So this is the course of the external. The tributaries, the posterior external jugular vein, which is here, is taking the drainage from the back of the neck, the transverse cervical, and also the suprascapular vein, which is the region of the posterior part of the scapula. And also, sometimes, or most of the time, the anterior jugular vein also is a tributary of the external jugular vein. Regarding the anterior jugular vein, there are usually the two veins that in the anterior cervical region, they are coming down. They are together here above the jugular notch, here above the manubrium of the sternum. This anterior jugular vein, they are joining together and they make the jugular venous arch. It's very important. Do you know what surgery we perform here in the respiratory system? Yes?
We have some kind of emergency and we need to get artificial source of oxygen.
Yes, so this tracheostomy. Yes? Tracheostomy or coniostomy. So it's extremely important that the surgeon must pay attention to this vein, because this is the jugular venous arch is interconnected of the two anterior jugular vein, and you cut the skin, you cut the fascia, and you go deep between the fatty tissue, and if you miss it, by the scalpel you cut it, then it will be a bleeding, and then you lose your operation field, your vision, and imagine that you penetrate the trachea, the anesthesiologist, it's remove the intubation, and it's really a stressful condition. Then you lost the trachea, because trachea in this region is going very deep, and then you have a matter of the seconds to put this intubation to the trachea, and then when it's bleeding, then the patient doesn't breathe by anesthesiologist, and you see the color of the patient is becoming black, purple, and it's very stressful. So that's why the surgeon usually really, before they go deep, they do the ligature of these two, and then they cut it, that it doesn't make the bleeding, and they go inside. So this is about the anterior jugular vein. The deep vein is internal jugular vein, which is, we mentioned it in the orofacial region and the neck region, is the main deep vein of the neck region, that parallel with this internal jugular vein, you have the deep cervical lymph node, that clinically absolutely important. The tributary, the main tributary, all the sinus of the dura mater, ultimately, finally, they are draining to the internal jugular vein via inferior petrosal sinus or sigmoid sinus. Fascial, lingual, there are variations. Sometimes the fascial and lingual, they join together and they make one trunk, and then they drain to the internal jugular vein. Pharyngeal, superior, middle thyroid, we are going to discuss about this thyroid, occipital vein. So those are the internal jugular vein. What is important, and definitely Definitely every student must know about the position of the internal jugular vein. Internal jugular vein is a content of the carotid sheath. These sentences, write it with the gold, and in the exam you have to say it 100%, yes? The content of the carotid sheath in the carotid triangle, you have it in the topography of the carotid triangle. There are three main items, or usually four. Dorsolaterally, content of the carotid sheath is the internal jugular vein. Ventromedially, the content of the carotid sheath either is common carotid artery or in the higher level is internal carotid artery, never external carotid artery. External carotid artery is not a content of carotid sheath. Between these two vessels and posteriorly is which nerve? Vagus nerve. Yes? And additionally, I can add in anteriorly is the loop of the ansa cervicalis. Deep ansa cervicalis is a descending branch of the hypoglossal nerve that is located anteriorly to this carotid sheath. But these three or four are very, very important. This is the another axis, not only subclavian and axillary, but also internal jugular vein also is a place for the central venous axis, which is important, and this is the content of the carotid sheath that we said. Internal jugular vein, internal or common carotid artery, depending on which cross section you will do, and between them and posteriorly nervus vagus. Definitely in dissection you have to find it. Those are the bigger structure in the neck region. You find the internal jugular vein. You know that medial to that it must be common carotid and internal carotid artery. Then when you find it and you clean it, you push away these two vessels, and behind them you can take out the vagus nerve. Finally, the blood supply or the venous drainage of the thyroid gland. You remember for thyroid gland you have superior thyroid artery from the external carotid and inferior thyroid artery which is from the thyrocervical trunk. But and the one arteria thyroida ima, that its variation, it's in the midline lower pole of the thyroid gland. It's making a drainage, but the only things that the artery, it's copying the course of the vein, or vein copying course of artery, is superior thyroid vein. Superior thyroid vein and superior thyroid artery, they are copying approximately the same way, but it means that the superior thyroid vein is draining to the internal jugular vein directly. Then we have the middle thyroid vein, that middle thyroid vein and inferior thyroid vein, that they are not copying and they are draining the rest of the thyroid gland. The inferior thyroid vein is directly emptying to the brachiocephalic vein. Middle thyroid vein is directed to the internal jugular vein. Remember, we don't have middle thyroid artery. Yes, we have superior, inferior, and ima. And here we have, but additionally, middle thyroid vein, which is draining to the internal jugular vein. There is a variation here about the inferior thyroid vein. Inferior thyroid vein, either you have left and right, and in this case, they are draining to the brachiocephalic vein, left and right. But also, it can be a arteria thyroida ima, vena thyroida ima, the same as arteria thyroida ima, that they are making a plexus, which is called impaired plexus. And usually, this ima or impaired plexus is draining to the left brachiocephalic vein, left brachiocephalic vein. The place that the subclavian and internal jugular vein, they are joining together, it's called the venous angle, a very important place for the drainage of the, or opening of the thoracic duct, the lymphatic, the biggest lymphatic duct that is carrying the lymph from the 3/4 of the body that you had in the lecture. It's coming from the mediastinum, is turning, make a loop, and it's open to the venous angle. So the junction of the subclavian and internal jugular vein, venous angle, and it's very important. In the left side, be careful, in the left side, it's the place for the opening of the ductus thoracicus or the thoracic duct. When it's open to this venous angle or angulus venosus, very important, again, pay attention. Internal jugular vein and subclavian, the union place that they make the brachiocephalic vein, this place is called venous angle. Left venous angle, right venous angle. Left venous angle is the place for the opening of the thoracic duct, carrying the 3/4 of the lymph from the body, and immediately before that it enter to this venous angle, they receive 3 trunk, the jugular trunk from the head and neck, right side, the left side, the subclavian trunk from the left upper limb, and the bronchomediastinal trunk from the superior part of the thoracic cavity. So there are the lymphatic drainage to the thoracic duct in the left venous angle. Similar to that, you have the right lymphatic duct. And right lymphatic duct, they have the similar right jugular trunk, right subclavian trunk, and right bronchomediastinal trunk, that they are carrying the lymph from the 1/4 of the body. It means that the right side of the head and neck, right side of the upper limb, and right side of the upper part of the thorax. And this is the cross section that definitely you have to know about the content of the carotid sheath. This is the carotid sheath, which is mainly by the fascia, for the pretracheal fascia is formed, and laterally the internal jugular vein, medially the common carotid or internal carotid artery, and between these two behind is the vagus nerve. So this is very, very important to pay attention about the matter, and thank you for your attention.